Good evening, all. I, Shreya from Torrent Pharma, welcome you all to Aging Spine webinar series. Today is the third webinar for all of us. The earlier series addressed the challenges of different management scenarios in osteoporotic vertebral compression fractures and the inevitable degeneration and management challenges in spine management. Thank you all for taking out time from your hectic schedules and joining us live today. Aging, they say, is inevitable. Sedentary lifestyle, improper diet, improper postures further adds challenges like obesity and muscle weakness. This all eventually takes a toll on our spine health and can lead to multiple complications. As the challenges arise, so do the new possibilities. And today, to understand the same, we have an expert panel with us. The topic for today is spinal tumors in elderly. Before we begin the program, let us all welcome our esteemed moderators for the day, Dr. Muralidharan and Dr. Manish Kothari. Dr. Muralidharan is a senior consultant and spine surgeon at the Apollo Hospitals, Chennai. Dr. Manish is a senior consultant and spine surgeon at the Jaslok Hospital, Mumbai. We have our panelists for today, Dr. Kedar and Dr. Amit. Dr. Kedar is a senior consultant and spine surgeon from Dinanath Mangeshkar Hospital and Research Center, Mumbai. Dr. Amit is a renowned spine surgeon from the Apollo Hospitals, Bengaluru. We also have overseas faculty joining us today, Dr. Marsin and Dr. Balaji. Dr. Marsin is a consultant spinal neurosurgeon based at the Royal Orthopaedic Hospital, Birmingham, UK. Dr. Balaji is a senior consultant spine surgeon practicing at Sunderland Royal Hospital, UK. A warm welcome to all our moderators, overseas faculty, and guest speakers. I'll now hand over the session to the moderators to kindly take us forward. Thank you so much.
Thank you, Shreya. Thank you. Good evening, everyone. Thanks. Would like to thank Torrent Pharma for their extended support for our third session on the burden of elderly spine. And today we take on about tumors in elderly. When you mean tumors, it's not only the metastasis. Though spine is the third commonest site for metastasis, followed by lung and liver. We also have other spectrum like hematopoietic tumors, which primary tumors, hematopoietic tumors, and also we have primary bone tumors. We have a fantastic panel and good case mix, and the motive is to give the management principles when you see a patient with a metastatic spine with cord compression, or a patient with a multiple myeloma, or a patient with a primary bone tumor. How do you approach? What are the management principles? And that's the goal for the session today. I will ask Dr. Kedar, our colleague from Bombay, and Dr. Kedar has a special interest in spine tumor. And Kedar, all is yours. You can unmute yourself.
Yes, thank you. I'll just share my screen. Can you see my screen now?
Yes.
Okay, just one sec. Okay. Good evening, everybody. Thanks, Torrent Pharma. Thank you, Manish and team, for organizing this and giving me the opportunity. So today the topic of discussion is spinal tumors in the elderly. So as we all know, tumors in the spine are increasing. Extradural tumors are increasing because the incidence of cancer is increasing, and people with cancer are living longer now because of improved modalities for treatment, newer chemotherapy, drugs, monoclonal antibody drugs, good radiation. So they are living longer, and hence the incidence of metastasis of the spine has gone up, and eventually they end up under our care, and we need to know of any algorithm or a method, a logical method of how to manage them, how to treat them. So I'm just going to talk briefly 3-4 slides on what is the current thinking about managing metastasis to the spine in elderly patients. So to manage metastasis or to manage any tumor, we need to do the best possible for the patient. So the best possible for a young and fit patient is different to what is best and possible for an old, elderly, frail patient. Also, the best possible for an isolated tumor is different from the best possible treatment for a tumor which is spread all over. So with this thinking, people have come up with scores which tells us how advanced their disease is. So one of these scores is the Tokuhashi score, which considers multiple factors and puts them together in a score to help us with management decisions. So if you go through the slides, on the top you see a thing called a performance status, which I will come to in the next slide, but that usually means how fit the patient is. So if the patient is fit, then he gets a score of 2. A poor patient gets a score of 0. The second point to consider is the number of extraspinal bony metastases. So if they have more metastases, the score is less, and that means we are not very aggressive with their management. So the number of metastases in the vertebral body is also one part of the score. Metastasis to major internal organs also is one part of the score. Primary site of the cancer is also a part of the score. So a very aggressive type of cancer like lung or osteosarcoma, stomach, bladder, esophagus, pancreas cancer, the score is less. And tumor which are slightly less malignant or more treatment options available for them, the score is higher. And for them, we can be more aggressive in their treatment. And also neurodeficit was also included in the Frankel's grading for the neurology. So Frankel E is excellent, which means the score is high, and Frankel A and B, which means the patient is non-ambulatory, so the score is 0. So all these scores were added up, and this is the Karnofsky's index, which was part 1 of the Tokuhashi score. So this just tells us how sick the patient is to begin with. And you add up the scores, and if the score is 0 to 8, then you go for conservative management. If the score is high, then you aim for excisional surgery, which is curative. So this is the basic management plan for management of spinal metastasis, spinal tumors in general. And there have been recent advances which have modified this plan. And nowadays, people are thinking in similar kind of framework, but because of the increasing effectiveness of radiation in the form of stereotactic radiotherapy and newer medications coming up, the management algorithm is changing. It is in a dynamic flux. So, but the fundamentals are the same. This is the norms framework or the norms classification, where N stand for neurology, where depending on what the neurology is, the flowchart varies. Then O stands for the oncology, which is the aggressiveness of the tumor to radiation. M stands for mechanical stability, whether the spine is unstable or potentially unstable, or the spine is relatively stable. And S stands for the systemic disease burden, whether it is limited or extensive. And depending on that, we have different modalities which are suggested. So as you can see in this algorithm, it is not a one thing leads to two things simple algorithm. There are multiple factors which are considered together, and there is no clear cut one pathway if you have 2 or 3 factors. So this is the framework for the thought process, and usually the management for spinal metastasis for any malignancy depends on a team approach which gives input for all these 4 options. And newer things are coming up because of advancements of radiation. There is a new thing recently which is called separation surgery, where you move the tumor away from the cord a little bit while removing a little bit of it, so that effective radiation can be used. So the aim of more aggression is reduced because of this separation surgery. Now, as orthopods, we are used to the instability scores for appendicular skeleton in the form of Miral's classification. So similarly, for the spine, we have the spinal instability score, which gives us an idea of how unstable the spine is. So if the score is from 0 to 6, then it is a relatively stable spine, and 13 to 18 is a definitely unstable spine, and in between is indeterminate. And like Mirror scoring, we have different criteria where you see where the tumor is, location, whether there is mechanical or postural pain, whether the lesion is lytic or blastic, and how much is the collapse, and whether there is anterior as well as posterior involvement. So all these things are considered together to give us an idea whether this spine needs stabilization or not. So these are the four scores I told you, Tokuhashi score and the Karnofsky index as part of the Tokuhashi. Then you have the norms framework, and then you have the SINS classification. So these give us a rough framework of how to manage these malignancies spread to the spine. Obviously, there are these lymphoreticular malignancies like myeloma and lymphoma, and the management of them is completely medical in most of the cases because they are very sensitive to radiation and the chemotherapy. So that is the O part of the norms framework. So having briefly seen this basic framework, we will consider the cases. So I'm going to present my first case today.
Kedar,
yes.
Can I just enter this, Murali? Just to for the audience purpose, we all know about this. See, you have covered two things very nicely. One is the prognostic scoring, which helps to decide whether you want to do a palliative surgery or a curative surgery, or you want to leave the patient longer. See, that scoring Tokuhashi and that score, it covers few parameters like takes into patient whether a patient is fit, general condition, and
Yes.
aggressiveness of the tumor. Is it a lung or a renal or a breast? So how aggressive the tumor is, and most important other one is the neurological deficit and other parameters, whether there is any extra spinal metastasis and things. So it's basically the general condition of the patient, the nature of the tumor, which tumor is it, how aggressive it is, and what is the spinal involvement, extra spinal and neurology. So these helps to decide whether you can manage the patient, how long the patient is going to survive, whether what we can manage, whether palliative or or a radical curative.
Correct.
So that helps to do it. And the SIN score you covered helps to say whether this lesion will fracture,
Correct.
whether this lesion will give instability. As you pointed out, like Merrill's, we always have the long bone fractures. We see whether this can be managed or this will break. So that score helps to give an idea that this will fail. So we'd go and do prophylactically something.
Yes, and then I also covered the norms framework, which is the current framework for management decision.
Yeah. So the two scores, one is for predict what you want to do. Other one is whether the spine lesion will fail, will fracture or something.
Correct. So predicting the fracture.
So this is what we are going to be talking about all of the session. These scores and these things, I presume.
Yeah, let's get on with the cases, Kedar.
Yeah. No, just cases. I think now scores theory is enough. So basically, so I'm going to show you a simple case, the very basic end of the spectrum. So I had a case, a 49-year-old female who was diagnosed to have medullary cancer of thyroid, and the tumor was advanced. It was spread to the lungs and multiple skeletal sites, including multiple spinal fractures. So patient presented with severe dorsolumbar junction back pain and mild difficulty in the walking. The patient was complaining of pain worse on bending and walking, so it was a mechanical type of pain. And the primary site was inoperable due to extensive spread of the tumor to involve the trachea and the vessels in the neck. So basically, this is her MRI. This is the T1 weighted sagittal on the one side, then the T2 weighted sagittal. And we have the coronal images also. As you can see, there are multiple involvement of the bones, but the worst involvement which caused her symptoms was the thoracolumbar junction. So this is D12 and this is L2, which is the L2 is fractured. There is a cleft over here. There is fluid over there. And also there is involvement of these thoracolumbar junction vertebrae. In my experience, the patient has metastasis at the thoracolumbar junction. If there's a fracture, then it is extremely painful because there is a fixed part of the spine, which is the thoracic spine, and the lumbar is very mobile. So these patients have a tremendous pain and mobility is difficult. Also in the coronal plane, you can see the involvement. So the patient was admitted, medullary cancer was inoperable primary. The patient was in extreme pain. She had some weakness, but not significant. Power was 4 plus to 5 out of 5 in her legs. And pain management was getting extremely difficult. So we admitted her and we got some imaging done. MRI already showed you. And the other imaging done was the CT scan to see basically how the posterior wall is. And we could see these fractures. The worst one was the L2 fracture. And looking at a general condition and the spread of the tumor, we did not aim for any heroic major surgery. What we wanted was simple pain relief for the rest of her life. So we had a multidisciplinary meeting. Obviously, the plan was to only palliate her, and we did the simple procedure, vertebroplasty under local anesthesia, and we covered the thoracolumbar junction 3 vertebra, D12, L1, and L2, which were the most involved and fractured. And it was a percutaneous method, local anesthesia. And in couple of bones, we use bipedicular, and the top one we use a unipedicular approach. And she got significant pain relief, and she lived for another 18 months after this. 1.5 years, so 18 months after the first procedure, she came with another cord compression higher up. But in that MRI, 18 months after the first procedure, we also included the lower part, and the bones have held up quite well actually for 1.5 years. So this is a simple procedure which is very simple, which is good value for money, and which gives tremendous improvement in the quality of the patient's life in pain management. So that is my first case actually.
Yeah, Dr. Kedar, fantastic case. So I have a few questions for you. So one is for the benefit of audience. How do you see clinically of what is a mechanical pain, what is an instability pain versus what is a tumor pain, and do you have some way of differentiating that?
Yeah. So it's a very important question because it helps a manager, make the decision as to what exactly is done. So tumor pain is pain which is there because of permeation of the tumor in the bone, and there is no fracture, but in spite of that, there is ongoing pain. And tumor pain doesn't depend on the position. Even if the patient is supine, the patient is continuously writhing in pain. So that is what I would understand as tumor pain. And for that, if there is no obvious cleft or space in the vertebral body, I wouldn't advise vertebroplasty. For that, better options would be either radiation, zoledronic acid, or calcitonin spray is what I would go for. Tumor-related pain, which is not due to any fracture. Mechanical pain is what we typically say in a spondylotic spine. It is related to the arthritis, degeneration, wear and tear. And instability pain is where there is structural, deficit. The structural column, the anterior column or the posterior column are deficient. And it is typically if the patient bears load on the spine or forward bends, flexes, then the patient will get this acute onset mechanical pain. Sometimes with this mechanical episode of pain, they can also get transient neurology in the form of mild weakness happening in a position, or they get radicular pain, which goes along with the mechanical forward bending. Right. So that is a mechanical pain.
Very important point here is when any movement causes pain or neurological symptoms, that is a definite sign of instability. So that should be picked up clinically itself, and the investigations have to be very aggressive in your clinic. Second important point you raised, Dr. Kedar, was of the tumor board. You said you discussed this with your tumor board.
Yes.
You have a more holistic approach to the patient rather than going aggressive, or how much to do is the basic
Yes.
question. So,
correct. So yeah, that is for any cancer oncological patient, I don't think a spine surgeon or an orthopedic surgeon should be making the decisions. We are not qualified to make management decisions. I think we should be part of a good team, which probably is headed by a medical or radiation oncologist. In this case, because of a thyroid, we also had an endocrinologist in our team. and a general surgeon, Dr. Lala Murad, he was part of the team that is inoperable. So it's like a
Yeah.
3-4 people coming together,
Right.
and then we make the decision. Palliation is
Definitely.
also part of it.
So in institutions, almost all institutions will have tumor boards, but there are many times for people outside institutions in private practice, it is good to liaise with your oncologist, have a good rapport with them, talk to them more frequently. It's not necessary that you take a backseat, but you need their input for what is the survival of the patient. Is he going to live long or not? And how aggressive should I be in the treatment? Can the pain be managed with conservative management, or should I go ahead and do something? So these are the basic questions, and you have a good rapport. The oncologist will definitely help you with that. Yeah.
I think that was see, Kedar, you hired multidisciplinary team, and as Manish, as you said, most institutions will have, but people working in peripheral, I think, as you said, it's good to have a connection with the network. There should be communication with the network and a pathway associated with yourselves, and it will all help for the fashion management. Good. Next, I think thanks, Kedar. We will have you back in.
So I'll stop sharing my screen.
Yeah. And we will ask Dr. Amit Kulkarni, spine colleague from Bangalore, to share his case and add on to the discussion.
Just 1 minute. Just let me stop sharing. Yeah, I've stopped sharing my screen.
Okay, thank you. I'm just, so good evening, everybody. I'm just sharing my screen right now. Right, so thank you, Torrent. Thank you, Dr. Murli. Thank you, Manish, for this opportunity. Kedar Kedar, my good friend and colleague, has already gone into the scores and the importance of that in making decisions, as well as a multidisciplinary approach. So I present my cases. So the first case is, to give a background, is a 64-year-old lady, an 8-month history of back pain, which was improving with osteopathic treatment. She had a worsening of back pain over the past 2 weeks and urinary incontinence for 1 day. Past medical history of note was sarcoidosis, and she was awaiting cholecystectomy for other reasons. Examination revealed a normal motor and sensory examination in the lower limbs, although the reflexes were brisk. The per-rectal examination was normal. The bladder scan, which is nothing but checking how much of urine is there in the bladder after voiding, was 262 mils, which is considered significant. Usually 200 and more is what is taken as inadequate emptying of the bladder. Then this lady was catheterized for urinary incontinence. She underwent an MRI of the whole spine, and that's the report there, along with the images, the most relevant images. So of note, there was a collapse of the T11 body due to an abnormal marrow infiltration and involving both the pedicles, causing a severe cord compression. In addition to that, there was involvement of S1, L5, T6, and T12. So quite a few areas in the spine already involved. So the question really now is, how do you proceed with such a patient? Do you do any other workup? Especially as, this is a patient who's presenting primarily to you as a spine surgeon. And do we do a biopsy first, or do we do a biopsy at the time of surgery? And what is the spinal treatment plan? Is it conservative in terms of radiotherapy and chemotherapy versus surgery? And in terms of surgery, it is whether we do it immediately or urgent or elective, and also the extent of surgery. And do we give steroids to these patients? So the workup which this patient had was a myeloma screening, which was a negative. She also had a staging CT chest, abdomen, pelvis, basically to look for any primary tumor which could be identified, or involvement of any other organs. And like the panel has already mentioned, a medical oncology opinion, as this patient was not known to them and presented to us for the first time. So this is the yeah, sorry, go ahead.
Yeah, you finish this image. Yeah.
Yeah. So this is the CT chest, abdomen, pelvis. No other visceral involvement or a primary was noted. I'll just give the scores, the tumor scores, and after that I'll put it to the panel as to what they think should how this should be approached. So the Tomita score, which is basically a surgical strategy for spinal metastasis, that score was 6, which basically means that these patients need short-term palliative surgery. The Tokuhashi, which Dr. Kedar has already gone through, was 7, which is for, again, conservative treatment versus palliative surgery. The spinal instability neoplastic score was 10, that is indeterminate and possibly impending instability. The Karnofsky of this patient was 90, that is quite a good performance score. So with this in mind, I just go back to the MRI and put it to the panel as to what they think should be done. Yeah. So just to recapitulate, we have a 64-year-old lady, first diagnosis of a tumor in the spine, which is which is multicentric. The most significant one being at T11, and the CT chest abdo-pelvis is not showing any primary, and the myeloma screening is negative.
Amit? Yeah. Thanks. Nice case. I got one question for you before we go to panel.
Sure.
Your lady has got a lot of red flag symptoms. For the audience sake, do you want to just alert what the red flag symptoms and how alert we should be? Because this case has got all the red flag symptoms. So do you want to summarize that in which red flag symptoms you're concerned and what are they?
Yes. So the red flag symptoms are basically symptoms which should warn any clinician in any setting that this patient needs further evaluation, and it's not something to be dismissed as just a mechanical back pain or something. So the usual red flags which we see, especially with relation to the spine, and which I think are most pertinent for tumors, is one is persistent back pain, especially if it is at the the mid thoracic or the thoracic level. Pain which is continuous, doesn't improve with rest, and which wakes up the patient at night, or rather prevents them from going to bed. The second thing is if this patient has a past history of any malignancy, and especially, it doesn't matter, the duration since the patient, since and if the patient was cured from this tumor. So it may even be 15, 20 years down the line from, if the patient has survived that long, which we see in case of, tumors like breast and things like that. And other things are things like obviously significant weight loss, and patients who present with neurologic deficit, which may be as subtle as, loss of balance while walking, or urinary incontinence.
Yeah, thank you. Well summarized, patient factor and all other things. So any patient with all these symptoms, they may not have all, but they may have few, but be vigilant. As you pointed out, thoracic back pain in elderly is a very, important thing to pick up. Should not ignore it.
Absolutely.
So we will take in-house panelist Dr. Kedar, see what he would do with your case, and then we will ask the NHS specialist Dr. Balaji, and see what he is going to offer for your patient.
Amit, what is the neuro deficit she has at the moment?
So motor and sensory power was normal, but she had, she was unable to walk because of myelopathic signs.
Okay. So basically 4+ out of 5, basically.
Yes.
And bladder and bowel were intact.
No, she had urinary incontinence.
She
was catheterized. So basically multiple spinal lesions, bowel bladder involvement without motor involvement.
Yeah.
Yes.
And unknown primary.
Yeah.
Yes.
Yeah.
So I think her performance index, and overall she is quite a well preserved lady according to you, except for this episode.
Yes.
And if her bladder is involved and she has multiple sites, so it is not a solitary site. So either ways, I think decompression and stabilization along with the sample needs to be done. We don't have the luxury of time with us now to sit and investigate and send more tests and find what is happening. So obviously we need to get the oncologist involved. But in this case, after giving her IV steroids, dexamethasone to start, then I think a soon enough surgery would help her in not losing her bladder and bowel control, because that is a big aspect of quality of life, is bladder and bowel control. So initially, quick investigations for fitness, oncology involvement, and urgent, or soon surgery, decompression and stabilization, and then send the sample.
Quick question to Dr. Kedar. Now that you've mentioned steroids, what dose that you give and what steroids do you prefer?
So in my practice, for malignant spinal cord compression, I usually start them with dexamethasone. I usually give it IV, and I start with 8 milligrams 3 times a day. And then as after surgery, then I taper it down. But I always ask the medical colleagues also. I always cover them with IV omeprazole or pantoprazole, because these high dose steroids tend to cause these gastritis in these patients. So that is my protocol of steroids.
Right. And we also look at serum calcium levels in metastatic spine. Many times their calcium levels are high. So that is another point that should be added.
Yeah.
If patient is in hypercalcemia, then your surgical risk will increase. You need to get your physician to correct the hypercalcemia and then probably take up. So if you look at it, this is like a very scary looking MRI. The cord is compressed. There's a tumor in the D12. However, Amit, you've managed to get an MRI and a CT done. So I'm assuming this was all have been done like within few hours of admission, right? So
yes. So, with regards to the timing of surgery, this is not something we would rush in the middle of the night. And definitely, like Kedar said, not keep it, for a few days. So MRI and a CT scan is something which you can, obtain within a few hours. And you have enough information at that point of time to, take an informed decision for operating the next day.
Yeah, Dr. Balaji, a quick question for you. You have this patient, is your patient. What are your thoughts? How are you going to approach to talk to the patient? The patient is the most important. And what are you going to communicate to the patient? And what are your thoughts on that?
So this lady has got a multi-level metastasis, which is the first time she's getting to know about this. So it's going to be all a bit of a shock for her when, you turn up and tell her that she's got, without having any background problems, all of a sudden that we're going to tell her that, you've got cancer, which is spread to all your bones. So it's going to need you need to take a lot of time to explain it to them. And so going through the whole diagnosis that they've got the metastasis, but the initial screening examination has not isolated what the primary is. And the most common reason is a metastasis rather than, a primary tumor of the bone itself. And with the way her clinical symptoms are, she is going to need an emergency decompression and stabilization to give her the best chance of getting her neurological function back. It's not a guarantee, but to give her the best chance to see what she will be able to recover.
Of course. So the diagnosis kind of takes like a backseat that, diagnosis can come later, but we need to protect your spinal cord.
Absolutely.
And that is the primary importance now.
And
then diagnosis will follow.
And hopefully the operation itself might help us with the diagnosis, because we're going to get tissue specimen to send, and that might be helpful. And there is a very small group where you will never be able to narrow the diagnosis or identify a primary source, which is actually becoming more common. But then that will be dealt by the multidisciplinary team of oncologists and, the other medical team.
Yeah.
I think there is a clear consensus, isn't it? So this is a case with a metastatic spinal cord compression. You will not wait for a biopsy alone. You will do a decompression, simultaneous biopsy and stabilization, and then MDT.
Yeah.
And then MDT approach.
Yeah. Many centers have this system of doing a frozen section. Would anybody like to do a frozen section on this?
It's not going to change what I would do. So I wouldn't think it's going to, because it's not a solitary lesion here. He's already said that it's in multiple levels. So it's a,
Yeah. So I think we can go back to Amit and proceed, show us what he did.
Yeah. Kedar, just have a question, because for the audience, see, this is the first time most of us will be seeing, because most of the time they come to us with a back pain and you discover this. And if your fellow sees the patient, and what investigations you would expect, like blood markers, from blood markers, basic, so that the people know, what we would be doing.
So, the investigations would be pre-op fitness type of investigations. And the second is, can we narrow what tumor it is type of investigation?
Yes.
So the pre-op fitness would be CBC, liver and renal profile, the coagulation profile, and viral markers. So these are the, what we do routinely. And what kind of tumor it is, can we narrow it down? In this kind of age group, I will always send a serum protein electrophoresis. That is standard. And if even if the serum protein electrophoresis sometimes comes negative, I sometimes also tend to send the quantitative immunofixation, because a lot of times these have these light chain diseases which are negative on serum protein electrophoresis. And because if it is myeloma, then surgery really takes a backseat. We can try to avoid surgery in myeloma, maybe not in this case because the bladder is involved, but even if you can find out, if it is a lymphoma or serum protein, the light chain disease, then, so that also is sometimes part of my thing. If the index of suspicion is high, this age group, 50 to 70, 60 age group female patient, that is, fertile ground for myeloma diagnosis. 40 to 60 female patient, myeloma diagnosis. So I usually go a bit aggressive and try to send quantitative immunofixation for light chain disease also. In this case, the other thing I have always seen is ask for history from the patient, because a lot of times female patients in India will not openly tell that she had breast cancer like 10 years ago. So we really, they will not say, they say I'm fine, mere ko kuch nahi hua tha. So we really have to ask them sometimes about thyroid or breast cancer or cervical cancer for that matter. They will not openly tell you this. They will not. You have to really tease the history from them, get them in a confidence and then ask them. So sometimes, we have had a surprise. We did all the investigation, including a PET CT, and in the PET CT they have said, oh, she has had a breast malignancy, so her breast is not there on that side. So that is embarrassing. So we need to ask history also.
Yes, yeah. So
One
thorough
quick
history is very
question.
important. Yeah.
One quick question to all the panels. There's a very practical problem that comes up, is that such a patient with neurological deficit, you are kind of inclined to give steroids, but you also have the back of the mind that this may be a myeloma or a plasmacytoma or a lymphoma, round cell tumor, where the steroids is going to affect the biopsy results. It may not give you the immunotyping. It will affect the immunotyping, and you may have to do a repeat biopsy sometime later on. So how do you make the decision, and how do you, what thoughts on that?
So I always say cord first, save the cord first. Even if you don't get a representative biopsy sample from the tumor site, they always do bone marrow later anyway. So final diagnosis depends on how much is the plasma cell percentage in bone marrow. So, cord first, because otherwise the patient is going to be angry with you, boss.
Exactly. Anybody else has a different take? Especially
I would definitely have that in the back of my mind about lymphoma, but I think sometimes your MRI can, give you a suggestion whether this could be a lymphoma, looking at the, your axial sections, looking for para-aortic nodes and stuff like that. If your index of suspicion is really that high, then, I guess you still have to give steroids, but,
Yeah, just a point to take here is that if the cord is not involved, probably you can hold the steroids and not go ahead with steroids.
If the cord is not involved, yes.
If a cord is not involved.
No, because we are talking about steroids, their general message may go out that steroids should be given in METs, but only if the cord is involved.
We had the same problem, Manish, few times, especially when you think it's like a lymphoma, should we give or not? I've spoken to hematologists and they said, don't worry, you will get blast cells from somewhere. So you will not miss the diagnosis. You can look at the CBCC whether there is an abnormal blood pattern, count cells or anything, but with biopsy we will get the blast cells. So you don't worry about one shot of dexamethasone.
I think we'll go back to Amit now. Let's proceed.
Yeah. So right. So just like Kedar mentioned, so the plan was we did. I did do. Yeah.
So Amit, one thing. Just go back to your score. From your scores, you're saying this patient, according to all the scoring systems, has a life expectancy of 6 to 12 months.
Yes.
Okay. I just want you to highlight the scores of
without the primary being known. Yeah. So.
Yeah. And your SIN score says it's going to fracture soon.
Yeah, it's going to fracture. It's probably unstable. Yeah. So I did a posterior cement augmented stabilization from T9 to L1 and decompression at T11. Taking down the pedicles and basically creating an area of separation between the cord and the tumor. Because of the low life expectancy, it was decided not to do anything further at T11, and we just augmented it with cement. And there was one more level which was involved on the scan at T6, and we filled in cement at that level as well. So vertebroplasty was done. There were no intraoperative complications, but she did bleed 1 liter of blood, and post-operatively she was fine with the normal motor and sensory examination post-op. So the specimens which were sent for a biopsy, shall I go to the biopsy next?
Yeah.
Yeah. So that's what the biopsy report came as. It was a metastatic large cell lung neuroendocrine tumor. So quite a odd tumor, or a relatively rare tumor to get, and it's quite an aggressive tumor, and it behaves almost similar to a small cell lung cancer. And the 5-year survival in a patient with stage 1 disease is 35%, so quite low anyway to begin with. And with metastatic disease, the prognosis is usually 6 months. Yeah. So the scoring systems did help us make a proper decision with regards to the surgery to be offered to this patient.
Yeah, so
Nice
with this
case,
surgery,
Manish.
Amit, you took care of her pain and you took care of her spinal cord. Important that you went 2
Yes,
above,
and
2
achieved
below.
diagnosis.
Yeah,
Yeah.
and you want that fixation to hold till she kind of succumbs to the disease. So you added some cemented screws
Yes.
as well. So yeah, fantastic
Yes.
case, Amit.
Yeah. I think the
Thank you.
biopsy, decompression, and stabilization compared to the first case shown by Dr. Kedar, see, there was mechanical instability, but no neurological deficit, and it was kind of so cement minimal, less invasive approach of cement augmentation vertebroplasty to give the stability, and that's what was done for the least invasive as an approach. And this one I think needed a bit more with instrumentation and emergent decompression. And now we move on to the next case. We'll ask Dr. Balaji, who's a spine colleague from Sunderland, UK, to share the how it's approached in NHS system. Balaji.
Yeah. Sorry, just trying to share the screen. Can you see my screen?
Yeah, we can. Yeah.
Is it on presentation mode or?
Yes, we can. Yeah.
Okay. Yeah. Thank you, Manish. Thank you, Murali, for giving me the opportunity to be as part of your panel. Thank you, Torrent Pharma, as well, for providing us, the support to do this session. So I'm just going to quickly touch on a slide of how we make decisions. I know this has been already alluded to by my colleagues. So surgical decision making, surgery for spinal metastasis is if they have neurological compromise and if they have mechanical instability of the spine. So how do we know that? Neurological compromise, you would pick it up from clinical examination, as already been described. And the instability of the spine, you would know from their clinical symptoms, if they are in significant pain, that they're not able to stand up or do anything, or even if they have rest pain. To know once you've decided that you think this patient can be offered surgery, you also want to know what their prognosis is. And how we know the prognosis is by knowing what the primary tumor is and also their functional status. And these two form the basis of most of the scoring systems that my colleague Kedar has already spoken to about. The Tokuhashi score, Tomita scores, and there are many more scores, but the most commonly used ones are the Tokuhashi score. So I'm going to go into my case. He's a 63-year-old man. He's a taxi driver. He's quite fit and well. He's had 2 months history of back pain. He actually points to like sort of the thoracolumbar area for the pain. And this pain has been gradually getting worse. He sees the GP who just says, it's been, he saw him at a month's time interval. So said like, just mechanical back pain, just get painkillers, rest, but it's not getting better and it's gradually getting worse. And one morning he wakes up and he realizes that he's not able to get up and walk. Doesn't report any bowel bladder problems. Because his symptoms have got so worse, he himself refers to have an MRI scan. He doesn't have any systemic symptoms. As I said before, he's a fit and well guy. He used to smoke previously, but not anymore. So on examination, he had tenderness in his thoracolumbar junction. His tone was reduced in his lower limbs. His power was 3 out of 5 in both the lower limbs and with altered sensation in the right leg. He had a rectal examination done, which revealed that he had a hard prostate, but he had normal anal tone, normal perianal sensation. He had the usual blood investigations, inclusive of full blood count, Usenis, CRP, ESR, and a myeloma screen. What I would stress is, if it is a male patient, always think about getting a PSA, because prostate is one of the most common reasons for metastasis. His blood PSA level was 1,300, which is very high, suggestive of likely that this is a prostate malignancy. He also had a screening CT chest abdo-pelvis to look for any cause. Just a second. So because of his significant pain, he went on to have an MRI scan, and this is his MRI scan. And that are the axial sections through the level where the lesion is. So because this showed there's multiple lesions throughout his spine, which obviously with his age, you have to think that this is a metastasis. He went on to have a CT chest abdo-pelvis to look for the primary source, which failed to reveal any primary malignancy, and there was no evidence of any other visceral metastasis anywhere else. Now, obviously, this gentleman has got quite significant pain, and he's got multiple metastases throughout his spine. We don't know what his primary is, other than having a very high PSA, suggestive that this is more likely coming from a prostate itself. How do you think we should take it forward?
So, Dr. Balaji, I think that L2 is L1 and L2 is the compressive site.
L2 is main compressive
L2
lesion.
is
Actually,
the main
what you
compressive
see,
site.
the axials is from the L2.
L2, and if I can see it correct, there is posterior involvement as well.
Yes, exactly.
There's a posterolateral. So that's the most important point you want to pick up. And the next, I think the CT chest abdo-pelvis will also give you an opportunity to look whether the mets are blastic, lightweight, or mixed.
There it is. It's got a lytic lesion at L2, L1, and also there's one higher up which is not projecting very well, but you could see on the MR that he's got lesion in the
bright light and stuff.
Yeah. Fair enough.
Okay.
So I think we can ask Dr. Kedar. You can ask go through the panel, I guess.
Yeah.
I think you're about to show up something. I think the score is there because.
So this gentleman has essentially got metastatic spine disease with mechanical instability. That the fact that he's also got neurological symptoms now. So really, he needs surgery. But is he a candidate for surgery? Is the next question. So to do that, we need to find out, what his scoring is to help us make that decision.
Yeah.
So even though clinically we know it's unstable, we've done the SIN score, and you can see he scores 13, which is indicating that it's an unstable spine. And he's had the Tokuhashi score, which comes to 13, again showing that he's got a very good prognosis. And this is one of the other more commonly used ones, which is called the Oswestry Risk Index. It's much more easier to remember because it uses only two things. One is the primary tumor, and two is what the Karnofsky score is. And with that, you will know what the survival is. The usual thing is if the patient has more than 6 months survival, then you would think about offering them surgery. That is usually the nice guidelines as well in the UK. So because the gentleman has an unstable spine and has got a good prognosis, the plan was to operate on him to decompress his spine and stabilize his spine. Would you all agree?
Yeah. So we have basically a spine which has neurological deficit, which is unstable. So it checks a lot of boxes for surgery, and he is overall fit. It checks a lot of boxes for surgery. So definitely this patient will need surgery. Point is, do you tend to explore other options? Do you speak to your radiotherapist that can we do this with radiotherapy? Or is this like a clear-cut indication that this patient needs surgery?
So all these cases usually get discussed in the MDT.
Yeah.
And, because he's got an unstable spine, their worry is even if they start radiotherapy, there is a chance that it can still fracture and we may have to need something. So they would actually prefer us to stabilize it. So then they can carry on, with the radiotherapy.
Fair enough. Yeah.
Was the patient walking? Could he walk? The patient?
He was walking with a lot of difficulty. He needed support. So that morning when he woke up, so till then he was walking with pain, but the morning he woke up, when he was really struggling, he needed two people's help to get out of bed.
Yeah, say if this
So I
patient
think
says,
that is when,
I don't need surgery, I don't want surgery, how do you counsel them?
so at the end of the day, it's the patient's decision. You really can't force anything on the patient. You have to give them the, the options. You have to tell them, like, you've got this unstable spine and you've got spinal cord compression, which is the likely reason why this is happening. And we are doing this to stop things getting worse and give it the best chance for recovery.
Exactly.
We can never give you a 100% guarantee.
And
so
it is
the patient,
it's a time-bound thing. So we have a narrow window of surgery. If we don't do it now, and we go ahead with the conservative management, then you come back to me after 7 days with worsening of symptoms, the results are going to be very poor, and maybe I will not offer you surgery at that point of time. So that message, I think most of us will give to our patients, that this is a time-bound offer. You can't use your card later on.
Absolutely.
But one thing I think I just wanted to, because probably in any bit we may not be able to say, I think we won't offer surgery if we come back later.
If he comes back with power 0 after 7 days, I'm not going to operate on this patient.
I mean, like, even if you offer an operation, you could just say, you can't say what your outcome would be. You can say the outcome
may not be good like operating like now, but you cannot deny surgery. Can you, Manish? I don't know. Ethically.
Yeah, of course.
Ethically.
There is no ethics. There is pure scientific data. There is very minimum or no functional recovery after more than 7 days of, rather more than 48 to 72 hours. There are very case reports and anecdotes. There is no hard data that is going to have any.
Let's see.
If you want to treat the pain, then you fix. But if you are offering surgery on the basis of neurological recovery, then that is ethically wrong.
What do you take, Kedar? How would you counsel?
Yeah, I mean, like, just this week, I have a patient admitted. He has got a lung primary, and he presented with paraplegia, basically. And he was transferred from Solapur to Pune. And the problem was the paraplegia was, there for about 10 days, basically. So he had bladder involvement, and he had zero power, and he was showing flexor spasms in his legs, basically. With he was saying, oh, I can feel your hand. A little bit of sensory sparing was there, but with his kind of lung with multiple meds and a paraplegia for 10 days, I told him, boss, I did not want to offer him surgery, because for the very fact was it will make him worse, basically. The current COVID scenario with a lung primary, that was like another thing. And there's not 10 days paraplegia. I don't think he was going to. Studies have shown that if you operate for malignant spinal cord compression, then the gain in power is by 1 grade. So if you have pre-op 3, then you will go post-op 4. If you have pre-op 0, 1 is useless anyway, power. Post-op.
Okay, exactly. Fine. We had an external colleague of us in the chat box messaging, watching us messaging. He will offer. Okay, let's not continue this debate. I just want to summarize before you show what you've done, Balaji.
Yeah.
See, Manish brought in a very good question about radiotherapy. Case of metastatic spine with a mechanical and neurological instability, neurological deficit. There was a beautiful RCT by Patchell, which got abandoned, called off in midway, where they tried radiotherapy alone, radiotherapy, decompression plus stabilization, and then they were called off because decompression stabilization was benefiting patients more. So they called off halfway, and that has been a historical cohort to say that neurological instability, decompression, and stabilization has a good role for the recovery. I think, Kedar, anything to add?
No. Perfect. I think we'll see what he has done now.
Yeah. Okay, good. Fine.
I've done minimally invasive stabilization, 3 up, 3 down. And I've also augmented the level because he has some tumor in the vertebral body at that level. So I've augmented that. And I've done a decompression at that level, L2 and L1. You can see that on the AP X-ray. You can see the midline cuff. And I've done a decompression. And his specimens came back as prostate cancer. And he was seen by the urology team. And he was started on androgen therapy. So he's 6 months out now. his disease is under control. He's had an CT chest abdo pelvis, has not shown any other new visceral mets or anything, but it does show the disease in that L1 and L2 itself is actually inside the vertebral body itself is a bit more progressive than before. It's not collapsed anymore. So that actually re-emphasized the point, and the radiotherapists are just happy to carry on with more radiotherapy because the spine is stabilized. If it wasn't stabilized, that further disease spread would only make it more difficult. And once they've had radiotherapy, risk of, with surgery, risk of infection, everything becomes higher as well.
Right. So there are a few questions here. Great case, Dr. Balaji. But as we said, we are working in a team with our oncologists and radiotherapists. So we need to think from their point of view as well. So there are a few points that we need to consider. Is when do we add anterior stabilization or not? And then, so this one was a partially blastic, partially lytic. The posterior part was lytic, but the anterior part was blastic, I assume. Right. So which is why
that's a very valid point, Manish, because I could see in the pre-op CT that the anterior half of the body is intact. So it's a great job you did not do any anterior stabilization and kept the surgery small.
Mixed pattern. Prostate is sclerotic, isn't it? Predominantly.
It can be mixed. Yeah.
Can be mixed. Yeah.
Because
mixed
you can see
saved,
the
I think.
CT.
See the CT only the
back.
Balaji, we have a question from our colleague from Calcutta, Prashant. Any consideration for pre-op embolization as it was from prostate?
No. Why? Are you concerned about bleeding with prostate?
So prostate
Kedar,
usually doesn't bleed, isn't it?
So prostate, we usually, I always check with the onco people, and as far as I remember, and all my previous cases, I don't think prostate bleeds that much to require a pre-op embolization.
Renal, I would be concerned.
Renal is
renal, we would be concerned.
Thyroid, renal, and sometimes even lungs.
Lungs,
I think just adding to that, as no anterior surgery per se was considered, I don't think embolization has that significant a role, for this case.
And this was minimally invasive anyway, so and it's only a localized decompression. So
good, Balaji. Again, I think the message here is the biopsy, decompression, and stabilization. And we have seen Amit doing it in one way, which is open way, and you have done it, I think, through MIS and a limited decompression midline. Is that right?
Yeah.
So that's one way of doing it. So you can use least invasive approaches as possible.
The
Thank you, guys.
Advantage of MIS is that at least at my center, we can send them for radiotherapy much earlier after an open surgery.
Less than a week, you can get them into radiotherapy.
Although MIS is an expensive surgery for the patient, lot of radiation to you, but it is worth the effort and the cost because radiation can be kind of fast track, and as faster results, pain also gets better quickly.
Yeah, I would agree with that. I normally now tend to do these MIS.
Kedar?
Yes.
See, you have done neurological instability. We have done the decompression stabilization. And when you would want your patient to have first setting of radiotherapy?
So if it is an open procedure, I definitely want them to finish 2 weeks, and the wound needs to be healed and the stitches need to be out. That is my criteria, and no question of a dry VP wound going for radiation. So it's not just 2 weeks, but the wound has to be dry completely. But if it is MIS, then definitely 1 week, I would be happy to proceed with radiation.
Okay.
Now that we're on the question of radiation, I just asked the panel, sometimes you get patients after radiation collapse. So how soon do you want to operate? Assuming you want to fix the patient, not just vertebroplasty. How soon do you want to operate the patient? Dr. Kedar?
So if they don't have neurodeficit, I would like to wait for at least 2-3 weeks. There is no rush. If there is neurodeficit, then the real question comes that you have to bite the bullet, basically. You have to save the cord. But if you try to save the cord, you might end up with a wound which is necrosed and not healing. So this has to be clearly explained to the patient that, this is a big risk with this. And the other thing is, if they've already had radiation, I definitely try to do as much of the surgery MIS as possible.
Yeah.
Okay.
Dr. Balaji, any inputs on that?
Oh, completely agree with that. Yeah, if there is neurological compromise, you just have to take the risk. But if not, then giving it at least 2 to 3 weeks time would be better.
So what I was coming to is that sometimes there is a window where the radiotherapy is not yet started, and it's important to communicate to your radiotherapist that I would like to do the surgery first, and then I'll do MIS, and then you can go ahead with the radiotherapy early. Sometimes some of these radiotherapists are of different school of thought, and they want to go ahead with radiotherapy first and then give the patient to us. So that communication becomes important.
Manish, on the similar kind of principle of this window of opportunity.
Yeah.
So if the patient is already on some chemo, then the patient is in a catabolic state. So we have to liaise with the oncologists also, because they need to stop these catabolic cytotoxic chemo, because otherwise what happens is the wound healing becomes a problem with the chemo.
Good.
Fantastic.
Okay.
I think we'll go to the next case now.
We'll move on to the next case. We'll have Amit back in. Amit, you can share your case. Yeah.
Right. So coming back, so the second case. So a 70-year-old gentleman presented with 4 weeks of continuous mechanical neck pain and a significant weight loss. He had a normal motor and sensory examination in the limbs. He was supporting his head in his hands, something like this, as he was trying to, kind of almost give traction there to support his head. He was investigated with the X-ray of the cervical spine, which is put up there. It's quite obvious that there is a destruction of the C3 vertebra there, and there is a kyphotic deformity. This patient had a subsequently had a CT scan and an MRI scan. The CT scan showed that, along with the C3, the C4 was destroyed as well, and the level of instability can be made out by the fact that the deformity corrects with the patient in the supine position in the CT scan gantry. The MRI confirmed the diagnosis that this gentleman had something quite sinister going on there at the immediate subaxial spine extending into the C2 and the odontoid. There was, although the cord was held a bit tight, there were no cord signal changes in that area. So, a question to the panelists now: what are we dealing with? Is it just to be? Is it an infection?
Amit,
is it a tumor? Yeah.
Amit,
or what are we dealing with? Yeah.
Amit, again, see your patient 70. Constant mechanical pain. So I've got all the red flags already. Yeah. Age 70, mechanical, constant neck pain, and your imaging shows an aggressive expansile lesion. So first thing is, am I dealing with a metastasis? Is he got any tumor elsewhere, or is it an aggressive bone? Primary bone or a benign or malignant bone? We don't know. So that is what my thought was. Kedar.
Yeah, exactly.
Okay. I mean, see, he has got involvement of C2 and C3, and also to the top
C4.
of C4 also. And I would like to study all the films of the MRI. Basically, is there any hint of spondylodiscitis type picture also over here? Because in India, that always we need to keep at the back of our mind. Tuberculosis is always I mean, it might not be that, but for a tumor to span the disc and destroy the disc like that 3-4 disc process, I can't see the end plates clearly, and even the disc is not appearing very properly over there. So it's unusual kind of presentation.
Yeah, absolutely. I agree with you, Kedar. And you can't take a decision just based on one screenshot of an image, which I put up there. So, what would you do now next to confirm the diagnosis and to work up?
I mean, we have a luxury of time with us. He does not have any neuro deficit. He has instability, and he's supporting with his hand, but there is no neuro deficit. So I think we need to work him up by doing admitting him, keeping him on bed rest, giving him a collar, treat this as an unstable spine with all the cervical spine unstable spine precautions and nursing precautions and log rolling and all that. And at the same time, start your workup in the form of blood investigations and then imaging. I would go for either CT chest abdo-pelvis is quick, you can do it immediately, or else if you have time, the better would be a PET CT where you can see everything along with that MRI, and then aim for a biopsy first.
Yeah, perfect. So that's the way. Yeah, that's the way we would proceed, isn't it? So first, is make him comfortable, and so that and then we can proceed with the bloods, followed by further imaging to check for possible primary. So that's the staging CT there, which he had, a chest abdo-pelvis. Rather, it was a CT chest abdo-pelvis. Staging CT is when they are already known to the oncology team. So it showed a right renal mass with lung mets, and there were no other spinal lesions. So nothing in the thoracic spine, nothing in the lumbosacral spine. We contacted the medical oncology, and their input was that this gentleman has probably a life expectancy of about 6 months. With that information, we then then we need to make a plan whether it would be surgery versus conservative treatment for this gentleman, or if it is surgery, the aim of surgery, the type of surgery, and the extent of surgery. That is, would we go anterior as well, considering that there's a big void there, or would just do it from the back? So to help with the decision making, we did the tumor scores. So again, not a very great score there. The Tokuhashi was 8. That means 85% people live less than 6 months with the score of 8. Tomita 6 to 7. So again, short-term palliation. And the SIN score, no surprise there, was 13. It's an obviously unstable lesion. And his Karnofsky performance index was 60%. So is that adequate information to make a decision, or anything more is needed? I'll come back to the MRI there.
No, that is adequate information.
Yeah, I think we've got a suspected primary, so it's a right renal lesion there, and he's got lung mets, and we know the prognosis. And we know that we can't, after discussion with the patient, that probably we can't leave this, alone, as there's a very high chance that either this gentleman will be in bed for the rest of his lifespan, or he gets a progressive neurologic deficit if he mobilizes.
So I'm sure Amit, you must have contacted the the urologist guys as well. Whether they are going to do anything about the renal mass, whether they're going to do a biopsy from the renal mass or not, and give a histological type to the primary. So
yes,
I think that would be my next step here before we take a call.
Okay. So, we did contact the urologist, and they said, you first, do your thing, and then, we will take over from there.
Okay. So I think this needs stabilization at the right away, because the moment he is at a risk of sudden catastrophic neurological deficit at any moment, my only concern is, so he definitely needs a long segment posterior to fix as many. So he already C2 is also involved. C2 is also involved, right? So probably occiput to lower down to C7, 3 levels down at least, and C7 pedicle. And then the question of whether to do anterior, because this is renal, this is going to bleed. So the question of doing anterior or not is very important here, because it is abutting the cord, and if you don't touch the anterior, very soon he's going to have a complete quadriparesis. So stabilization, of course, can be achieved easily, but anterior is the question here. So that I will base on the histologic type, because there are certain renal cancers which are kind of amenable to immunotherapy. There's newer modalities which may control the disease better, and that will be best provided by a histology.
Yes, yeah, absolutely. And the other thing also to think, practical point, doing an anterior, after obviously stabilizing it from the back in an elderly gentleman with 70, a high cervical, the patient also needs to understand that they are probably going to end up with some serious swallowing problems, and that's something which also has to be taken, on board.
But I mean, now we have a clear that it is a metastatic renal aggressive lesion. And yes, this is the one I think we were discussing before. These are the ones which would need a preoperative embolization if you're planning to go anterior.
Yes, anterior. Yes,
I would.
absolutely.
Sorry, I couldn't work out from the sections itself. Obviously, I would look at the coronals to see how lateral they go. Is there a chance that it could be involving the vertebral artery? I would do an angiogram to see if it's involving the vertebral artery, and also that'll help you know about any significant feeder vessels, which will help with the embolization as well. And
Yeah.
I have been involved in a similar case, but it wasn't as much into C2, but it was pretty much C3, C4 downwards. But once you've done the embolization, I think you would be able to. My preference would be to still go anterior first.
Okay.
For someone with
Okay.
a 6 months prognosis, Dr. Balaji, someone with a 6 months prognosis, what is your aim of going anterior?
The main reason why we're doing this is to provide stability and also pain relief as well. I have a feeling whether just doing posterior, it's going to, really provide that. Especially when you see, because you might do the surgery and come out and you might see very soon the tumor actually becomes quite expansile and goes on and compresses. In spite of you having done the posterior decompression, it might not actually be of much use.
But probably you will do that as a staged, isn't it? You will do that as a staged. Yeah.
Yeah.
Okay. Right. Yeah. So this is what we did. So basically an occipitocervical fixation with actually a double rod construct. So like, Balaji said, for this to hold with such a massive void at the front, just on two, rods at the back is, it's quite difficult sometimes to, comprehend that.
Lateral mass screws, depending on the lateral mass screws.
Yeah, that would depend on the lateral mass screws, So what we did was, along with the routine occipitocervical fixation, we added on a double rod construct, something similar to what we do in, adult sagittal deformities to, increase the rigidity of the construct. And that's where, the, newer implants, do give us an edge. And the extreme right image shows that, it does look like quite a solid construct there.
Right. So I just like to make a fantastic fixation. Amit, just like to add that nowadays this stereotactic radiosurgery, they are even treating renal cell with stereotactic radiosurgery.
Yes. Yeah.
So this will be like a very good case. Even those renal cell carcinomas earlier thought to be radio resistant can now be given 1 or 2 doses, high doses of radiation, which is more image guided around the tumor, and that might achieve some local control. So at least cord compression in the future can be prevented with stereotactic radiosurgery. Anterior support to give or not to give is a debatable question, and that depends between the patients and the surgeon.
Yes. Yeah.
Manish, just for the audience, I was just going to say that stereotactic radiosurgery is not surgery. It is strategically applied radiation with the newer equipment. Isn't that what you are saying?
Yes.
Radiosurgery?
Yeah.
Because some must say it's a type of. It's not a type of.
It's not like cyberknife. Yeah.
Correct. So it's just like well applied radiation, so that the cord is spared and maximum dose goes to the tumor. So stereotactic radiation is a newer form of radiation.
So just to summarize the radiation part. So what we had earlier.
Stop sharing.
Yeah.
What we had earlier was conventional external beam radiotherapy, which was typically given in low doses over 10 to 20 sittings, so that the cord is spared and the surrounding tissues are spared. These are more likely parallel rays of radiation which go in 2 planes and affect the tumor, goes through the cord, through the visceral organs, but in a lower dose. With this image guided radiotherapy, you can give much higher doses specifically at the tumor, and the surrounding areas get very little or almost no radiation, and this works like a 360 degrees convergence of radiation on the tumor as per the software. The oncologist or the radiotherapist will sit down on a computer, make a map of the tumor based on the MRI and CT, and then calculate dose at each level. So this is basically a radiation, but in a more comprehensive way, focusing or rather, kind of converging all on the tumor, and higher doses can be given. So conventionally, which were radio resistant, are now amenable to some form of radiotherapy. So this is IMRT, image guided radiotherapy, or you can also call it as stereotactic radiation.
Yeah, thanks, Manish, for summarizing that, because the conventional radiotherapy, we are all worried about this, effect of it, dose, and for the fractions we give on the spinal cord. But now the advanced radiotherapy helps to, narrow down and with a lesser effect, side effects of it. I've got two questions quickly. I just want one of the panelists to give the answer for the audience. What instruments do you use? Titanium, carbon fiber in cancer surgery?
Titanium.
So I think most of us use titanium. Carbon fiber, most of them are cages, which are, there's a whole question of cage. So while, as I was talking about radiotherapy, when you're doing anterior reconstruction, you need to consider your radiotherapist's plan as well. If you put a titanium cage, they are not usually very happy. But if you put a PEEK cage or a carbon fiber cage, there is less scatter of the radiation and they are usually more comfortable. So is the case with cement. They are more comfortable with cement over a titanium cage. So if you are doing an anterior reconstruction, best avoid a titanium or a metal cage anteriorly. PEEK is better, bone graft is better, cement is better.
And just to add to that point, Manish, now Dr. Murli is sitting in Apollo Chennai. They have the proton therapy center there.
Yeah.
So if you are going to use post-op proton beam, then they don't like metal over there. So they want this carbon kind of thing for the proton beam.
Yeah.
One more question from the audience. Steroid. Do you have to use dexamethasone if you know you are going to get a biopsy or something?
Steroid is only if there is a cord compression and neurodeficit with it. If the patient presents with no neurodeficit, I don't think there is any role for a steroid as such.
Yeah.
Or pre-operatively, if you're going to do cord handling, or there's going to be some retraction a little bit, it's better to give steroid pre-op and then a single shot post-op.
Yeah.
I think the question is indicated that if it is a completely radio-sensitive tumor like a plasmacytoma, so do you want to give steroid or do you want to send away directly for radiation? So I don't see any harm in giving steroid even before radiation if you have a biopsy already.
Diagnosis, yeah.
I think we discussed about this earlier, I think, isn't it? The cord compression is steroid. Yeah. So so we had seen now metastatic thoracolumbar, and then we have seen it's not only limited to thoracic and lumbar spine, even the cervical spine is not spared. Now we move on to next spectrum. I will just run through it. So 80-year-old lady is a man, a retired policeman, normally independent, active, mobile. The performance is 80, above 80, so which is very good for him at this age. 3-month history of thoracolumbar back pain, axial back pain, unrelenting back pain. 2 weeks history of bilateral leg pain and been bedbound. 1 week history of bladder bowel incontinence using incontinent pads, but no clear history of loss of appetite or weight, no constitutional symptoms, no trauma. So you can see is a motor, he has got a variable weakness, but no useful motor grades, and everything is less than 3. And he had a sensory D9. Catheter tug was present. Only thing is he has had some sacral sparing. And you can see the upper motor signs. And Asia B, a sensory incomplete picture. So this is a clean X-ray which worried me at down here, where I have loss of pedicle morphology, like off owl's wing sign. And then here you can see the body, collapsed body. Then we get a immediate MRI to see what's happening, which shows a solitary lesion with the compression on the cord. Then we get a CT. CT shows a little lytic involving the posterior body with a soft tissue expansion, which you could see as well. So now I've got a solitary lesion, PET CT, no visceral mets, with the right pedicle involvement, lamina, mechanical pain, Asia B, D10, is it metastatic spinal cord compression or is it a primary some tumor? all the scoring says is about 12 to 24 months. What are the options? Solitary lesion with neurological deficit.
Sorry, Murli, what's happening at T12?
T12.
Yeah. Is there something?
Yeah, he has got some upper end plate fracture. But MRI, the T1 and everything is fine. He's got that. We don't know whether it is the part of the lesion or just but like compression end plate, superior end plate fracture.
We don't know the primary yet.
Yeah, we don't know the primary.
Okay.
He's 80.
It might be quite difficult to do the scorings without knowing the primary. Do you agree? Or?
Well, now I've done it retrospectively, na.
Okay. Yeah.
At this stage, he's a solitary lesion, 80-year-old solitary lesion with a
Okay.
neurological deficit.
And he's got neurological compromise as well. Yeah.
Yes, basically it's a difficult choice.
Yeah.
But at his age, if it was a younger patient, I would be thinking in terms of an en bloc. But at the age of 80, with a cord compromise, I think it is pertinent to offer him decompression and stabilization to save his power and his bladder power.
Yeah.
So, I don't think we need to think heroic over here. He's 80 and his, this survival is 12 to 24 months. So, I mean, I don't think trying to cure it is going to be in my mind. I don't know about others, but I would go for decompression stabilization.
Could you show the axials, please, Murli?
Yeah.
Is there any axials?
So, Murli, he's incomplete, right? I mean, he's quite weak, but he's incomplete. So
sacral sparing, just sacral sparing.
Yeah. So that's an incomplete lesion, isn't it? So he has got everything to gain from decompression. So with a 12 to 24 month prognosis, I would aim to decompress, fix, and do a fixation such that it will last at least 2 years. So reconstruct the anterior column as well. So scoop out and
Balaji, axials, there is right side lesion with epidural mass. That's it. Nothing else.
I would do decompression and stabilization. I wouldn't be thinking about any anterior here.
But what would be your now PET-CT is normal in 80-year-old. It's a solitary lesion. We have sent the benzone's protein, serum electropulse. So everything is going to come next day or now in the evening. So you have done an urgency X-ray, MRI, and CT. And you've got this situation, so you're going to make a decision to do something.
Yeah, but how long has he been? I thought he's been like this. His neurological deficit has been like this for a few days, isn't it?
No, weeks.
Few weeks. So it's not an emergency to be doing in the evening.
Yeah, it's not an emergency to be doing in the evening. My question is, what is the likely diagnosis? Have you got anything on your provisional, on the mind, based on this picture? At his age, solitary. We definitely need a biopsy. Biopsy
can still be. I'm not still sure whether this is just a solitary and that there isn't something that we're not seeing. But I'm not going to treat him like as if it's a solitary bone lesion.
Okay.
Because this has already breached the posterior element. I'm sure there must be something in the posterior, or at least the posterior wall is breached.
Yeah, in CT as well, you can see there is a epidural mass.
Yeah, so this really, you can't do an on block in this. This is not like, this is already breached. So you're not going to be able to do a curative surgery in him. Yeah. So my principles would be decompression, stabilization, and then finding the diagnosis and treating it accordingly.
Yeah. I think the whole panel has got the same consensus. So decompression, biopsy, stabilization.
Yes. I mean, the construct should last.
Exactly. Yeah, that's a very important question here. Is that the construct should last for a good 2 years. So I would not hesitate to go long.
Yeah, as you can see, as well as expert, we can see there is a fracture on the lamina on the side. So I did what you guys said, same, and 2 level above, 2 level below, everything from back to 360-degree decompression from back. The specimens turned out to be, plasma cell origin. And the serum electrophoresis next day came back showing M band and everything. So it is looks like a solitary plasmacytoma. And he has been discussed with the oncologist, hematologist, and they've taken him on the board for radiotherapy to start. He's been 3 weeks.
Started steroids and all as well. You must have started, right? Dexamethasone. Have you started the steroids also?
Yeah, initially, yeah. When he presented to us, yeah. That was initial protocol. As soon as we receive them, they have metastatic cord compression, we do them. I just want to ask one thing. Do you guys use cement beads when you addressing from back, reconstruct? We're not doing a en bloc, but
Done the
palliative ones.
fellowship using cement alone, not with the metal inside cement, just a cement block alone with a wire in it. I've done that in the cervical and also in the lumbar, but not cement inside the cage.
Amit, do you back the body with the cement beads? Cement?
Yes. So basically, take the Palacost cement and in the cavity, just drop the beads and just pack it in with the fingers actually. And the cervical spine, I use a 2cc syringe, fill it with the cement and just put it there, with the K-wires like Bala.
Kedar, do you use cement at all to augment the body when you do some debulking?
No, because the cage itself is quite strong.
Oh.
So I mean, like bone graft is no, because we might need radiation, so the bone graft will not last there. But the cement, I'm not sure how much strength will increase with the cement.
Okay. Okay. I thought because the metal might fail because it's not. If she lives longer than a couple of years, probably the cement would stay longer than the cage. So that was my rationale. Manish, one thing I just want to ask: are you there? Will the cement impede radiotherapy? And anybody has got any thoughts? Will it impede?
I'm not sure. I'm not sure. I haven't heard anything like that before. But maybe we need to check with the radiation guys. I don't think it helps.
Fine.
I don't think it scatters the rays, so I think it's quite good. Okay.
Now, Amit, you can start sharing. I'll stop sharing and we'll move on.
Right. Okay, so coming up to the third case, and final one from my side. So background history, a 83-year-old lady presented with acute on chronic back pain with radiation to the left thigh, difficulty walking and getting out of bed, which was very recent, progressive weakness in the lower limbs, and urinary incontinence. She was previously mobile with a frame, significant history of ulcerative colitis, for which she had an ileostomy 10 years prior, and atrial fibrillation on rivaroxaban. So went ahead with the investigations, and this is the MRI scan. The one on the left is so that's the MRI scan there. So just looking at it, what are we dealing with? Is it are we all happy that we are dealing with something sinister, or is it an osteoporotic fracture, or any thoughts?
I think it clearly
just on those images.
It clearly has all telltale signs of
tumor,
malignant fracture.
Yeah. So and just to enumerate that, that would be on the left side. You can see that the pedicle is actually involved on the extreme left, which is something which you see in malignant infiltration. And on the extreme right, you can see that the bulge of the the posterior vertebral body into the canal, which again is one of the pathognomic signs of radiological signs that this could be something more sinister that we are dealing with. So this lady had a CT scan as well, and this was the picture. It didn't show any CT chest abdo-pelvis was all negative, and this is just a few cuts, the sagittal and the axial, at the level of L2. So any thoughts just looking at that?
A sclerotic lesion, isn't it? It look. It's not a typical involving 3 column.
Yeah, it's almost flea bitten kind of this appearance, kind of, isn't it? And there's a significant soft tissue, this component, and that's just the cauda equina there, all compressed into that one small dot, which explains that, which explains why she is weak in the legs and has got urinary incontinence. So I just we have discussed it, but is it an osteoporotic fracture? We do agree that the MRI signs in this case are quite pathognomic, but this lady was on probably long-term steroids, and that is the first thing which would usually come to mind. But going through the MRI scan, we have gone through, and it's most likely to be a malignant, a malignancy going on there. Any further investigations anybody would want, or are we happy to go ahead with a management plan directly? I don't have any scores. I have to apologize for that.
Yeah, I think we have gone enough about the scores. I think probably you can show us. So,
yeah.
Kedar, what are your thoughts?
I think again with neurodeficit, we don't have the luxury to investigate too much.
Yeah,
we need to get on and decompress and fix, and then you can take your time investigating.
Well said. Well said. Yeah.
Perfect. So let's not go around in circles. So I'll just show what I did. So yeah, so we thought it was most likely to be met there, and did a L2 pedicle subtraction, created a curated out the posterior half of the vertebral body, and put in a bit of cement there, and basically decompressed the cauda equina and created sufficient space there between the tumor and the dura. And just because it was a lumbar spine, I opted to go short and use segment augmented fixation, and corrected the deformity at that level. Shall I go to the biopsy next?
Yeah.
Yes.
Yeah. So surprisingly,
but here again, see again the same principles. If it's a neurological deficit, whatever it is, urgent decompression, biopsy, and stabilization, giving mechanical stability is the key. And then we wait for biopsy and then MDT and everything.
I would have gone 2 levels up and down because now you're committed to, maybe you might need anterior reconstruction. But to go 2 levels up and down, maybe you can get away without anterior reconstruction.
Yeah, actually, so yeah, I think that's a very good thought. What I did in the posterior column to compress it down. I thought that would give it anterior this. That was my thought, and I just wanted to give her more mobility in the lumbar spine. So yeah, so surprise, the histopathology.
But you augmented with the cement, the above and below, so probably increase the stiffness of the construct. So okay. And what is the histology then?
Yes, absolutely. So it is a very stable construct. So it was suggestive of chordoma.
Okay.
Yeah.
So was that a surprise? Was that a surprise?
There.
Was that a surprise?
It was a surprise, to have a, rather than, I think, the worst case scenario we could have, or the best case scenario would have been a solitary met, but, here we're dealing with a primary tumor. So, altogether total, different, a thought process.
Kedar, you would have done anything differently? The approach would have been the same.
Not at all. I think her fate was sealed when she presented with neurodeficit.
Okay.
So there is nothing else we could have done.
Okay. Fantastic. And what was the MDT discussion again?
So so we did run it past the oncologists, as well as took some more spinal opinions with people dealing with primary tumors, and they felt that considering her age, comorbidities, and the fact that we had created an adequate plane there, that she was not a candidate for further surgery, and she was then managed by the medical oncologist.
Okay. Thank you. Kedar, just quickly from your experience, see the chordomas we know mostly of the sarcoma or the clivus and above things. These lumbar ones,
they are rare. Common is sacrum and craniovertebral junction.
Yeah, craniovertebral.
Very rarely you get but in such an old age group, it's very, very unusual.
Very unusual, yeah. And we know for chordomas, it's purely the surgical full radical excision is what the treatment.
So chordoma, the treatment of choice, if it's a single thing, is an en bloc. And nowadays, the new therapy is the anti-brachyury drug imatinib, and also this carbon ion heavy metal radiation that which you have in Apollo now. That is the that is a some people say that we might not even need surgery if you can have a carbon ion or a proton beam for these chordomas.
Fine.
I'd just like to add one thing there. I had once sent one patient of chordoma to proton, and they did not. They said do radius surgery first, and they refused proton. And the cost is prohibitively
high.
Yeah,
true.
Yeah,
stop you sharing. Can stop sharing. And Kedar, we'll move on to the next of yours.
Yeah, just a quick one. One sec. Okay, here we go. Okay, can you see my screen?
Yeah.
Okay. Okay, so basically, this is a case where I have a 59-year-old gentleman with history of left renal cell CA, left radical nephrectomy done 2 years ago. At that time, he did not have any metastasis. He presented to me with worsening back pain and mild difficulty in walking. And MRI spine was done, PET CT was done. And what we could see was a solitary metastasis at L1, L2 level in the spine. Rest of it was negative. So these are the PET CT images, axials and sagittal and coronal, which show high uptake or high SUV max area in the posterior elements of L1 and L2. So this is the MRI scan, which T1 and T2 sagittal images, which show a big lesion involving the posterior elements of L1 and L2 with no involvement of the body in the front. So, so that is the case basically. A PET CT which shows a solitary lesion in a 59-year-old gentleman with back pain and some difficulty in walking, and history of nephrectomy done for renal cell 2 years ago. So shall I just proceed with what I did, or do we want to discuss anything as to what should be done?
I think Dr. Kedar, just show what you did and why you did. So you can summarize.
Okay. Yes, so basically we decided to go for a curative treatment over here because although he had a solitary, he was youngish, he was 59, and it was a solitary lesion, and he did not present with gross neurodeficit, so we did not have to rush in. So basically, being a renal cell, we decided to do pre-op embolization to reduce the vascularity, and we did an en bloc excision. So there's a lot of planning which goes in the en bloc. I don't want you to read all this, but each and every step of the en bloc we document as to what exactly needs to be done so as not to violate the tumor margin. Because our instinct as orthopedic spine surgeons is to dissect and go down to the bone, and which is exactly not what we need to do when you are trying to do an en bloc. So we have to fight our instinct, and then planning and discussing and making a plan beforehand is always helpful. So this was the thoracolumbar fascia incision. This was my plan of what all bones we need to remove, including the pedicles, the transverse process, posterior elements of L1 and L2. And this was the rough planning, which I usually always do pre-operatively as to what all needs to be removed. This is the planning in the coronal thing. So each and every section in coronal CT also I decide and make a plan, what bone, how much exactly we are going to remove. Here we cannot go from inside. So here for the pedicle cuts of L1 and L2, my plan was to go from outside in, not from inside out. And this is the CT scan which shows completely osteolysis of the L1 spinous process posteriorly at that level. Again, further planning and further planning. So planning is all in these on blocks. And then this is what I like to see in my report of the pre-op embolization, where anterior spinal artery we need to locate, which is the right D9 level. So we are not going to be close to that. And good amount of embolization. I usually go and personally see what they embolize so that I know what exactly to expect. This is our planning for the incision. There was a biopsy also done just to be sure that this is not any other second pathology. So we needed to remove that skin paddle. Plastics were also involved in this. And we removed the whole thing on block. If you can see, we have cut the L1 pedicle, L2 pedicle. And if you can see, we have removed the posterior elements of L1, L2, and also of top of L3. So L1, L2 posterior elements, all the muscles on the top, including the fascia, bit of skin, we all removed as complete en bloc. This is 2 years post spine surgery and 4 years post surgery. He had some wound healing issues because of the huge dead space and seroma over there, but we did not need any flap or anything. Eventually it healed. This is the scar of his previous renal nephrectomy. So I asked him just last month how he's doing, and he's doing quite fine. He's back in his town. He's working also. And then the proof of the pudding and the icing on the cake is a PET CT 2-year post-op, which shows negative for any FDG avid hypermetabolic pathology in the region surveyed. So left renal and the operative. So 2 years post-op, there is no recurrence. So this is a case of en bloc for metastasis. If it is solitary and if it is removable, then it is worth it, because potentially we have cured him or we have given him a long-term disease-free survival, which otherwise if we had done only a local curettage or non-en bloc, it would have recurred and caused further compression for sure. Thank you. That's my case.
Nice case and planned very well, Kedar.
Yeah, fantastic case, Dr. Kedar. What the intent here is the most important, that the intent is curative and you do whatever it takes to cure this patient, because that will significantly increase the lifespan of the patient. And whatever the morbidity, you don't think of the morbidity in this too much, because you're a young patient and we can achieve cure. So you go full blast maximum and take the tumor out.
Thank you.
Yeah, I think so. Murli, we can't hear you, Murli. Unmute.
No, renal has got a very good prognosis.
Yeah,
Yes.
which is why he went for curative, right?
Median survival is very good. And what I just want to highlight, Kedar, see, you highlighted the importance of preoperative planning.
Yeah.
And very important, these kind of cases are dealt in an institute by the experienced unit.
Yeah, correct.
It is not like the other metastatic tumors that we dealt where we debulk, decompress and give a biopsy stabilization. These are very as to a meticulous planning and everything. And I think that has to be dealt in an experienced unit. That's what I would give the message to the audience.
Excellent. Thank you. I'll stop sharing my screen.
Yeah. I think we have covered what we wanted. I think we're still missing Marcin because he's got some late minute emergencies. He had got few primary tumors, chondrosarcoma and angiosarcoma. But I think if he is not, I think he must be still with the emergency. So I think we have covered quite a bit. Manish, you want to summarize it?
Yeah, so I think we had a fantastic case discussion. Overall, a wide variety of cases were shown. For the audiences, what we need to approach the patient is very important, that your mind has to be clear in what you are looking at and what are you going to do with it. Two questions that you want to see. So in what you're looking at, you want to see what is the primary coming from, whether there's neurological deficit or not, or whether it is unstable or not. These are the three primary questions that you have to ask at the first instance. What is the primary? Why? Because whether it is radio sensitive or radio resistant, whether there is neurological deficit with a significant neurological deficit, because you want to first do surgery or you want to first do diagnosis, and third is unstable. If it is, then you need to fix it at some point of time. So that will help you make your decisions easier. And of course, you need to know what type of tumors behave in which way, which you can easily read up anywhere. And instability, those fantastic scores that we talked about, this really has helped us spine surgeons to make very easy decisions whether to fix or not. At least not easy, but at least it has kind of given some clarity to that conundrum of whether to fix or not and how much to fix. Many times how much to fix also depends on what life's expectancy we are looking at. If someone who's going to be really short, then we'll do a short or quick job. Someone who has a long life expectancy, you want to achieve fusion and probably a long
Manish, I think Marcin said he's able to join now. So 5 minutes, if you can find, that will be great, I think.
Yeah. So just to summarize, the most important changing paradigm more in the West, it's slowly coming into the metros in the India as well, is the radiotherapy, higher, newer, more image guided radiotherapy, which has kind of changed our way of how we look at spinal meds. More than 30, 40 years ago, when the people were only doing decompression for spinal cord compression, then we moved on to fixation and decompression. Then we moved on to whether should we fix at all or not, then finding out which are the radio-sensitive tumors, which are the radio-resistant tumors. And now the definition is kind of becoming again blurred, that many of the earlier radio-resistant is now going to become probably radio-sensitive with more higher radiation doses to be given there. In certain scenarios when the tumor is very close to the cord, what we call as tumor separation surgery, you want to give the cord some breathing space so that high doses can be given. In surgeries where you are unable to take the tumor away from the cord, the radiologist, the radiotherapist will not be able to give higher doses radiation. So you try your best to take the tumor away from the cord, not necessarily take away entire tumor, but make it away from the cord, and that will at least give him a better chance. So that means you need to take out the tumor which is in the epidural canal, as well as you want to take out the pedicles also, because the pedicles are in very close proximity, and whatever you can take out from the anterior posterolateral side of the cord, that you need to take out. So I think Marcin is
Marcin
here.
is
We'll
here,
get
yeah.
on with his case.
Okay.
Hey guys.
Thanks, Marcin, for joining us. Marcin is the spine surgeon at Royal Orthopedic Hospital, Birmingham, UK. Royal Orthopedic Hospital is one of the accredited tumor center. Marcin, you can share your screen and you can show your cases.
Yeah. Thank you
Thanks
for
for
having
joining
me.
us.
Thank you for having me. Still late. Kader, I love your mustache, man. I'm about to share my screen.
But he has lessened your work. He has already went through all the pre-op plans and everything.
Yeah, great, perfect. So I'll show you. So which case comes first? Let me do this one. So it's a case of a 67-year-old. That's a good one to start with. 67-year-old lady presented with back pain and a left leg pain, which was mechanical, kind of stenotic pain. And she felt a mass in her left flank as well. There was nothing worrying in her past medical history, and neuro exam was intact, but indeed, there was a palpable mass in her left abdomen, upper and lower quadrant. And and that was her scan, quite impressive, with this tumor rising from L2, but extending all the way up to the diaphragm almost, and lower down in the retroperitoneal space, pushing the kidney and the bowels away. As you can see on the screen, I don't know if you can see this bit in here, the psoas was attached to it. So the CT-guided biopsy done by our radiologists with a midline approach. As you can see, I put this slide just to emphasize the need for the midline approach for a query primary tumor. The CT appearance consistent with chondrosarcoma, which was actually with the CT-guided biopsy. And there was a question whether it can be resected en bloc or not. We would, that was case that we did at the Royal Orthopedic Hospital before both Mel Granger, a senior colleague of mine, really experienced in primary spinal oncology, and myself moved to QE, as we've discussed before. So we would always display, in terms of planning, we would always display all the scans, T1s and T2s, with all sections, just to have all the tumor visible ad hoc during the operation, and that's how much it extends paraspinally. Mel and myself felt that it was doable to resect it en bloc, even though it would have to be a major undertaking. Basically, 3 consecutive levels. I think this scan will show the best, with the possibility of going through the disc above without violating the tumor. And obviously the tumor itself would have to be taken out from the front, while its posterior approach would be utilized to mobilize the tumor from the back and stabilize the spine for the forthcoming resection. So the perioperative plan, I'm just putting it whenever I present this case or talk about the envelope resections, I put this two pieces of paper. If you look carefully, you can see the tape. There was actually a photo taken from the wall, so that's the plan drew down and kept on the wall in theaters. When we operate, everyone has got access to it and can ask a question or see what actually we're doing at this particular moment. The plan is being cross-checked. We always write the plan down, both of us independently, and then we discuss it before the operation, and then maybe modified. And as you can see, that's a live photo. That's how it looks. It's not always great and perfect and beautiful. It gets changed sometimes. And then during the operation, I think Kader, you would remember this.
Yes,
you
yes.
visited a few times, and it was like that, and it still kept like that. So whenever we are in the middle of the operation, or somebody gets bored, or somebody wants to go home, scrub nurse or the anesthetist, they will always ask, which point of the plan are you at? And it's enough to tell them that it's we've only spent 8 hours operating, and it's 0.6 to put them off, and usually it's not that bad, of course. So the first challenge of this case was to design the cuts. So posterior approach, as you can see, the instrumentation, nothing really special, even though we've changed recently. We started using S2AI screws for cases that we need to go to the sacrum. It's stronger, it works better, following our internal audit. We needed to allow the cuts mobilizing the specimen to be available to be finished from the front and started from the back. That was the only safe way of doing it. So we left, basically that was the depth of the cut to the vertical body from the back, with pedicles visualized by this squares. The jiggly saw, or we use T-saw, Tomita saws. They are much more delicate than jiggly saws. It's basically a wire. It was buried into the cut to this, more or less, this depth, and that was all packed with Surgicel, preventing it from moving towards the cord while the patient was de-anesthetized and then pampered, prepped for the second stage, which was done few days later. It wasn't the same anesthetic. It was just too lengthy procedure, both of them, to risk having them done under the same GA. So this worked quite well. It was the invention of the day. Essentially, it was all about keeping the wires of the T-saw, keeping the wires of the T-saw in position and make them available to the front, push them towards the retroperitoneal space and make them available for us during the final stage. So transecting this part of the disc. Disc is usually the structure that we would cut through, and preventing them from moving with the Surgicel turned out to be a good idea. The second stage was the anterior approach, and that's obviously that's the closure. I would always show it first, just to visualize the extent of the exposure. And obviously that was done with general surgeons, actually retroperitoneal surgeons, who would be very helpful. And that's the first stage of the approach. You can see the tumor here. Obviously, we needed to resect a few ribs. Chest was open, diaphragm was cut eventually over there. This is the aorta, and these are viscera, left side of retroperitoneal content. So with the spleen, pancreas, and kidney mobilized in one chunk. That was a proper visceral rotation that actually served the purpose. And that was the access to the specimen. So the tumor is right in here, and it's attached to the spine in this area. These are our T-saws that we are able to fish out from the back. We found them. It wasn't easy at all, but we made it at the end. It wasn't as smooth as we thought it was going to be. That's what I meant. Yes, following the cuts being accomplished, we were able to deliver the tumor, and then XRL cage. The dura is here. The posterior metal work is visible from the front. That's nothing unusual during en bloc resections. Aorta, and everything was put back, and that was the specimen. And luckily, we had negative margins actually in this case, which was quite I think quite a big deal. So she didn't have any major issues. Obviously, she spent like 2 months in. It wasn't a straightforward recovery, but she was able to mobilize, and she's been fine. So that was probably the biggest case, biggest successful case I've been involved in. So we did it. We always operate as 2 consultant team, just to make it safer. I've learned tons from this case, and it was probably the most spectacular I've ever seen. And it went well, which is always great. So that's my first case. And the second case, I'd like to share a case that didn't go that well. If we've got time, can we do that?
Yeah, quickly, 3 minutes.
Yeah. Okay. I'll do it quickly. So here's the case. Just let me display it. Play.
Yeah, again.
Okay. 61. Thoracic pain, no deficits. Just back pain. That's very often first presentation.
You have to move your screen, I think.
Oh, really?
Yeah, we have not. We cannot see the next one.
No.
That you want.
Okay, I am share screen.
I think it's fair enough, isn't it, Kedar, to say that again? The same principles, isn't it? To be dealt by the institute. These are not the ones that dealt everywhere. It has to be dealt in the experienced unit, MDT approach. And CT, preoperative CT, even the CT, they have to plan. Sorry, the biopsy they have to plan.
So if I'm doing an on block, I am thinking about this case for at least 7 to 10 days before surgery.
Yeah, that's right.
Every day I'm thinking and visualizing and what I will do, and I'm dreaming about that case for 10 days. Then
that's what the pre-op plan is. Key thing. Yeah, very good.
It takes time. I completely agree. So this was a biopsy-proven angiosarcoma, mid-thoracic spine. As you can see, a bit of destruction, hence the pain. But he had extend above and below, and above with the PET scan. So that's the MRI, extending paraspinally quite a bit with a bit of cord compression. Again, neuro intact pre-op. A guy with a bit of cardiomyopathy, but otherwise reasonably fit. 61, so not bad at all. Grade 3 biopsy proven. And now PET scan was quite important from the planning point of view, because it showed the majority of the bulk was at that level. And then there is an extent to the adjacent vertebral body, but then there was increased uptake along the pleura, going up to the disc space 3 levels above or 4 levels above the bottom level of the disease. And there was a question whether we should do 4-level en bloc for this or not, taking into account that probably it spreads still along the pleura, but we just cannot see it on the PET. And with angiosarcomas, they're very aggressive. Grade 3 hasn't got good prognosis. So yes.
Just on the PET scan, on the right side kidney, is it what is it? Is it something?
No, that's normal kidney. That's the normal metabolic activity. It's just asymmetrical cut.
Fantastic.
So there was a big discussion with the guy and his family. The family read quite a lot about oncology, about operations, and they, I wouldn't say insisted, but they were in favor of radical resection that was offered to him with lots of reservation on our end. But as it was the only way of trying to cure him, there were options given to them, and the least favorable one by the oncologists was en bloc resection, but joint decision was to go ahead with the operation. So he had pre-op angiography, again plan
Plan as it is. Yeah.
displayed resection involving two entire vertebral bodies and cut just to resect the extent, pleural extent. And the intra-op, it looked quite okay. The extraoral cage, that's the favorite one, Expedium 635, strong system. So both chest cavities were opened. We don't reconstruct the pleura. We don't reconstruct the chest wall. I know it's a controversial topic. Haven't seen any major problems. So bone graft and our sausage grafts, and that's the post-op X-ray. I think it looks quite okay. But the guy presented 8 months later. We did have negative margins, and so it was all good. And then Pat, with the him presenting with pain, you can see there is a disease in adjacent area of the spine and also below the level of the screws. So we basically got tricked by the biology of the tumor, and I show it as a case proving that you cannot win the biology, and probably PET not being the optimal way of finding out the extent of the disease. What is actually, we don't really know, but the overall gut feeling prior to approaching this case was that we shouldn't be offering him en bloc. That's why I put this en bloc option as the most bottom one, least favorite one. There's always a discussion, you know, the family dictated you what to do, and you did a crazy big operation, exposing the patient at all risks of en bloc resection. Well, he was given a chance, the best chance he could have been given, probably, and unfortunately, disease progressed regardless. So that was it. Progression of disease. I think he was out of this world a few months later, unfortunately, because of the systemic spread.
These are the very nasty ones, Marcin. I
remember
because see, I spent 1 year with at East Midlands Sarcoma Service in 2010 with Rob Ashford, and we used to see a lot of soft tissue sarcomas, and he always used to say, if you get anything but not the angiosarcomas.
That's the thing. In primary bone oncology, you cannot win the biology, unfortunately. You can be excellent surgeons, but it's not going to work, sadly.
Thanks, Marcin, for joining. See,
thank you guys.
We went through metastases. We went through cardomas, and we went through.
I saw the agenda. It was great.
Yeah. We went through, and these are the extent, because people always think when it comes to sarcomas, the chondrosarcoma, it's all younger age. They always think it's younger, or middle age, younger age. But we see, in elderly, what are the these primaries, how they can be, presenting and challenging. But these ones are the ones that to be dealt in institute by the expert team, with everything. It's not the ones that can be managed peripherally. It's for our audience. So,
and how would you manage chordomas in elderly population?
See, in NHS in UK, if anybody picks this up, they get directed to the accredited centers. You have 5 or 6, 7 centers. Yeah. But here, at the moment, we don't have accredited centers, but we have few institute doing, and then people have to be directed. Kedar, what is it? How is it evolving? The spinal oncology.
So I spent 5 years at Hinduja in Mumbai, and the reason I did a few of these cases, these are rare cases, primaries or solitary metastasis for en blocs, is because it was already an established tertiary center with Manish Agarwal as the orthopedic oncology guy pulling in all the cases. So for any spine thing, I used to be the main surgeon and he used to assist me. So that way, and we also had a general oncosurgeon who's very experienced guy from Tata Memorial who had joined Hinduja. So it was a 3-member team. So anything needed intra-op, whether it's vascular mobilization, bleeding control, whether it's bowel mobilization, whether it's lung resection, pleural resection, the 3 of us could manage everything, whether it's pelvis, visceral mobilization. So you need a team. You can't do it on your own, and you don't need a team who never meets for the rest of the year. You need a team who meets every day and then they are ready to take on such a big challenge.
Yeah,
Fantastic.
I agree. I completely agree.
Okay.
And that's
Okay,
one of the
guys.
reasons of me moving, to QE. Basically, these guys
QE.
are always there. Yeah.
Okay. Good. Thank you, guys. I think it was a fantastic
Thank you.
show. Marcin, thanks for joining. Although you had a lot of commitments, but it's good to have you and
Thank
see
you
your
for
work.
having me. Thank you.
Shreya, I would like to thank Torrent Pharma once again for the extended support for all these continued series, and my panelists and my colleagues and everyone. Thanks for contributing your time. Shreya, are you there?
Yes, I'm there,
Yeah,
sir.
we are done. Thank you very much. Thank you, Kedar.
Thank you so much
Balaji,
to
thank
all
you.
the wonderful speakers.
Amit, thank you all.
Thank
We
you,
can
guys.
quit now. Yeah. Bye.
Yes, thank you, Dr. Balaji, Dr. Martin, for joining us from overseas, Dr.
Thank you
Muralidharan, Dr.
so much for
Kedar,
having me.
Dr. Amit. It has been such an honor, and these series shall continue, and I wish a very safe and healthy weekend to all of you. Have a great day.
Thank you.
Thank you.
Thank you all.
Bye.
Thank you all. Bye. Take care. Yeah.
Bye.
Bye.